This conference will now be recorded.
Okay, gents. Good evening, everybody. After an absent week, it's Rick Davis. I'm moderating tonight, and I welcome everybody. Fairly big crew. Nobody new. Um, I just a quick thank you to the sponsors who are right now, because some are in renewal, but those we know we have are um, Janssen, Bayer, um, Myovant, um, Sumitomo. No, Sumitovant we don't know yet. Um, Telix. I think I think those are the for sures, and then we've got a few people that are Myriad. We got a few people that are all turning now, so we're in a churning period. Okay, we don't have anybody new, so the first person I'm going to go to is Tom Jacobson because he asked for time a couple of weeks ago or 3 weeks ago, and then I didn't get to it. We didn't get to him, so we owe one to Tom. So Tom, you're up first, man.
Thanks, Rick. I won't take a lot of your time, but I do have a couple of subjects. One is about radiotherapy, and I am presumably oligometastatic, and I I have I've gotten mixed messages on so supposedly I have maybe five metastases, and they're pretty close in on the pelvic girdle. Um, I'm just wondering the thoughts on getting radiotherapy versus what my doc says is just leave it alone. And it's a confusing subject, and to make it a slightly more confusing is my gut feeling is hit the outer sites with SBRT and leave the prostate itself alone. And I'm just wondering from the peanut gallery what your thoughts are on this.
Well, it's a great subject to kick off with because I think there's at least two other guys on the call right now that are faced with it pretty much exactly the same issue. I think this is an issue that's on Gary Zellner's radar, and it's possibly an issue that's on Paul Frieder's radar, although not clearly yet because I don't think he's had the PSMA, and maybe a few of the other guys who want to talk tonight. So I'd like to throw it open. Just quick question for you,
Yeah.
um, which is, are you did you switch to darolutamide, and are you still on darolutamide, or are you not on a are you on
Yeah.
hormone treatment right now?
Yeah. I switched to Orgovix and darolutamide, Nubequa, and that's what I've been on for some time.
Okay, and how are you
And
doing on the Orgovix? On the
well,
Orgovix
as far
Nubequa?
as I know, I'm doing okay. My PSA is still undetectable, as it's been for a long time. Um, so my oncologist says, "Hey, don't worry about it. You're doing fine." Um, and then there's that other creeping feeling that, well, maybe I should be doing something about this,
Hmm.
which I had a year ago, and I did meet with a pretty well renowned radio oncologist, but I didn't do anything about it because it's easier just to say, well, if you think it ain't broke, don't fix it. But of course, it is
Yeah.
broke, so it's a quandary.
Right, right, right. how are you feeling versus when you were on the enzalutamide in terms of the being on the darolutamide
I I can't tell you, Rick, that I really can tell the difference.
difference?
Um,
Okay.
I mean, the major thing I feel is fatigue, and that could be just the timeline, not the drug itself.
Right, right. So I'm going to we got a hand up which I hope is relevant to this conversation. So I'm going to go to Joel to kick off the conversation. Go ahead, Joel.
Yes, I would say hit it with all you can up front. I had two sessions of SBRT, one to my left iliac bone and one to my right occipital condyle bone by a radiation oncologist. And there's no cancer there anymore. Dr. E is sending me right back to that radiation oncologist because she found 4 spots of dormant cancer. My PSA is also less than 0.04 for the last 5 months, but I'm going under radiation starting next Monday for 5 sessions for my thoracic spine, and 2 spots on my lumbar spine will be addressed in December for with 5 sessions of SBRT. So Dr. E, my GU medical oncologist, believes in hitting the cancer early and hit it while it's asleep and don't let it come back up.
Hmm.
Thank you.
Who else either wants to chip in on this or is has really the same question as Tom?
This is John. So you know how with certain treatments like chemotherapy, when the cancer's asleep, there's really not an opportunity to take advantage of the fact that fast-growing tissues are vulnerable and slow-growing tissues are not. So what about with radiation? I mean, radiation is capable of killing any cells, whether they're asleep or not, right? We don't have to worry about the fact that the PSA is non-detectable and that we're radiating inactive tissues, do we?
I mean,
Well, can I respond to that? Um, a part of my confusion here is that you only know what you have based on what's detectable. So I never was able to get a PSMA scan before my PSA was dropped so low that it wouldn't have been meaningful. And that's part of the confusion. So I'm assuming that I have a handful of sites that could be treated with radiation, but I don't really know that. Um, and it's a difficult place to be in because you can't really, at this point, I can't really get, as far as I understand it, an accurate PET scan that will help me understand how good or bad is the situation.
okay, so now you're raising another important issue, which I missed, which is that these 4 or 5 spots you're talking about, they are what you assume is there. You don't know if they're there. They're not evidenced by your PSA because you're on hormone therapy. So really what you're saying to us is, how do I determine if I have spots and whether I should radiate? Is that what you're asking, Tom?
Yeah, I mean, and I've asked this question before. So a bone scan, a full body bone scan, and a CAT scan showed these sites, and it's been
Ah,
consistent. I've had 3 of them, um,
okay.
but that doesn't mean that there's not something else. And it's a little confusing, you know. So what I said to my oncologist, well, if we were going to go the radiation route, what is the what is the mechanism? What is the um, what is the analysis to determine the target? Is it just, you know, are we just going to use what we've done before with a bone scan? I'm just kind of, I feel like
No,
I'm
I
teetering
get
on the
it. I
fence.
mean, I get it. I mean, I think it's a little more complicated than originally I was hearing, which is that we're not sure where all these spots are because you haven't done a PSMA scan.
Right.
So, you know, there are a couple of ways to go here. And let's see what the guys think. I mean, one of them is to take a holiday right now, allow your PSA to rise to around zero point 0.2, and then to do a PSMA test at that point and see. If it turns out that you've got 10 spots, then we have to think about a different treatment than if it turns out you've got 2 spots
Right.
and we don't know. So, you know, should you radiate 2 or 3 spots that you see without the knowledge of where everything else is? What do people think about that?
Rick, can I comment?
Absolutely.
Because Tom is going through, it's hard to tell, but I think he's at a stage where I was maybe a few years ago, where I had about 4 or 5 um, mixed bone lesions and lymph nodes, pelvic lymph nodes. And I was sent over to Michael Zalewski of Sloan Kettering, who is now at NYU. And his recommendation was, well, I think you're probably better off just on the hormone therapy, and then we'll take another look, more imaging down the line and see if maybe there's only 1 or 2 left that we can target. And then I ran up against what you ran up against, which was that pretty quickly my PSA was at or near undetectable levels, so there was no point in doing any scanning. Uh, so I never did any spot radiation until after I went on a 21-month drug holiday. And then like Rick was saying, the PSA rose to a point where I was able to get a PSMA PET scan. Now, here's the important part, because I have additional lesions, but they're not the original ones when I first started the darolutamide. Let's see, it's about 4 years ago now. Those had gone away. Now I had new lesions, new pelvic lesions, and new bone lesions. They were sub-centimeter small, but if we tried to spot radiate lesions that were showing up 4 years ago, it would have been a waste of time because that's no longer the problem. So I guess bottom line is I would do what Rick is suggesting, just uh, go on a drug holiday, let your PSA rise, and then get an image, PSMA PET image.
So here's my problem with that logic, because I understand what you're saying and I've thought about that. But what you just explained was, I believe you said you went on a holiday
Yep,
and you had new lesions.
yep.
So we will try to wonder, well, were the new lesions the result of stopping the ADT,
Quite
or
possibly.
would they have been there anyway? And that's what makes me crazy about this kind of stuff. It's really hard to, well, it's really hard to get. I mean, you could say that, sure, take a holiday, and your PSA is gonna rise. Okay, I can understand that. But are we playing with fire, or what? I mean, if my PSA is undetectable and it's at least an index of where things are, is it crazy to take a holiday just so I can get a PSMA scan that will be detectable? That
Well,
makes
the
me
point,
feel crazy. I'm sorry.
no, that's all right. The main point of the drug holiday is the drug holiday. You know, you're no longer on any medicines. You feel good. Your musculoskeletal system is strengthening. Your immune system's coming back. No hot flashes. That's the benefit. The
Understand?
risk, of
Yeah.
course, is new lesions. Now, I mean, you don't have to do that. You could just stay on the meds you're on now, and you know, for another couple of years, and maybe you'll still be undetectable. That I guess is your only other chance.
I mean,
And
that's
Len,
that's the question. That's
and
the
Len,
question, and
right.
I appreciate the answers.
Yeah.
It
But
just makes me
Len,
feel.
would you radiate the spots that can be seen on the CT scan right now? If you were doing that, if you were staying on?
Well, I'm not sure that the CT scan is picking up a lesion that's active or that was previously,
Mhm.
you know, treated, or
No,
if it's
the full body bone scan will pick up the lesions on the bone,
Yeah,
not the
but
CT scan.
what Len is saying is, are those active lesions or are those lesions that are dying and have left? Because
yeah, it
we
could
don't
be.
really know. And unfortunately, some of that expertise is going away because we're relying more on a PSMA scan. Peter G, you wanted to say something on this.
So I was kind of like in your same position a while ago, where I was in a position where I went to Mayo and they wanted to let my PSA rise to 2 or 10 and do scans, find the cancer, and do kind of the whack-a-mole effect. You know, find it, whack it, find it, whack it. And there was a second opinion that was put me on ADT until it stops working. Because eventually it'll stop working, right? It's not like a lifelong suppression medicine. Sooner or later it stops working, 3, 5 years later, who knows? But it's going to stop working. And I figure when it stops working, that's when I could start doing the PSMA scans and the whack-a-mole and the whole 9 yards. But if I can get a good 5, 6 years, 8, 7 years maybe, of a half decent quality of life out of it before I have to start doing the whack-a-mole stuff, that's kind of the direction I took. That's why I went with Dr. Anarakis at the U, because he just said, stay on ADT as long as my quality of life is good and don't worry about the rest. And when the cancer starts beating it, then we're going to work on it. I mean, that's kind of like but I was at a crux point where it's like, okay, do we actually start to actually actively, proactively go look for it? Or we just passively sit back and let it sit and kind of manage it almost like as a chronic disease.
Mhm.
I'm right there with you, Peter. I mean, that's the crux of what I'm talking
And
about.
and right now I'm managing it as a chronic disease until it beats the ADT. And it will eventually, like I said. And then
Well,
it's then
there are a lot of guys who are using spot radiation before they even get on to the ADT.
mm, mm,
So they see a spot and they may not be put on ADT immediately. They may be, but it depends on the doc. And then they'll hit those spots. And then maybe if it comes back, they'll hit them again and they'll go on ADT. But you can do it that way round or the way you're doing it. Tony Fig, what do you got to say on this?
I was just wondering if a consideration also should be the radiating the bone lesions and having it harm the production of red blood cells. If some testing should be done with the status of your blood cells before you get into radiating
Um,
too much.
it's a good point, and usually there are ongoing blood tests. Everybody should be getting ongoing blood tests. It depends also on the location and how extensive the radiation is going to be. If it's in an area where there's a lot of bone marrow, yeah, I think it could be an issue, but mostly with spot radiation, my experience is that's not been much of a factor. Um, but I defer to Len or to Dr. John or one of the other docs on the call on that one.
I can't, this is John. I can't really speak to that question, but I would like to ask Joel, when he and his doctor decided to go after aggressively and hit it while it's asleep, was your PSA also non-detectable at that point? And how did the decision work out?
Yes, that's correct. PSA was undetectable at that point. I'm also on Orgovyx and darolutamide. I have been on that for over a year, and Dr. E plans to keep me on there for another year. So, yes, she's the one who decided it. I mean, she caught me flat-footed because I was in her office in August in Houston, and she says, "You have no more cancer." Three MRIs didn't show any cancer. Yeah, PSMA PET, which was the fifth one I took, showed no cancer. And I was sort of flat-footed because I didn't know what to tell her. I mean, I didn't know, and usually I have an opinion about what to do next, but I did this that time because I didn't know I didn't have any cancer, showing at least. And so that's when she brought up that I'm going to go after the dormant stuff. And
Hmm.
and so when I went to my radiation oncologist, 2 points here is that if I had gone to him first, he would never have radiated anything. But because the order came from her, he then took an MRI of my spine, again undetectable PSA. Took an MRI of my spine, the spot she was talking about, and lo and behold, the radiation oncologist said there's cancer there. And so that's why I'm going for radiation in November and December here, SBRT, because it's worked before on me. We know that SBRT kills the cancer. I know that about that. And so that's the whole plan.
Hmm. Thank you.
So I do have a suggestion for you, Tom. Um, but before that, I just want to acknowledge that Peter Kafka put a note in that there's also the use of spot radiation for palliative, but that's not the discussion that we're having in here right now. We're not
Not right
really
now.
talking about palliative. We're talking about strategies for long-term management of the cancer using spot radiation for oligo, which is a little bit different. We talk about um, having a certain level of PSMA, of PSA, in order for the PSMA scan to work. But what we overlook is that that is for guys where we don't know where the cancer is. If you've got cancer, and if that cancer is active and it is, and you are PSMA avid, now, and some, unfortunately for you, you don't know if you're PSMA avid or not because you've never had a scan. But if you are PSMA avid, the chances are those spots will show up because we've seen them. The reason why you have to have a high enough PSA is to be sure that there are spots around, because that's what gives you. But we know that there are some spots there because we've seen some stuff going on for a while. They might show up, they might not show up. I mean, if they're active, they'll show. If they're just lesions as a result of um, having been cancer that's been removed, they won't show up. But one way or the other, um, it might be worth still getting a PSMA scan right now. That's the strategy I want to suggest, and see what shows up.
This is John. You know, there were men in the Arches study who had radiographic recurrence without having biochemical recurrence.
Right.
And it
Right.
was a decent
What does that
percentage,
mean?
like, I don't know,
What does that,
15
could
or
you
something.
explain that? What does that mean?
That means that there are some people in this study who didn't show a PSA rise, yet did show um, a rise on scans. And that was done before PET scans. That was done with MRIs or CAT scans. So it is possible, as Rick says, that something could show up even though your PSA is undetectable.
But what are we thinking something would show up? The same thing that already has shown up, or something different?
Well, if that's what shows up, you know that there are spots that need treating. If more shows up, we know, and if you've got more than 5 spots, we know that maybe we've got to take a different attitude. So we're just giving you some ideas, but I
That's
think if
right.
something shows up, you could come back, but it's too speculative right now. I want to keep moving because there's at least one
Yeah,
person we want to get in before
yeah.
I
Thanks a
think
lot for
his
you
9
guys.
o'clock.
I know that took a lot of time. Thank you.
Okay. Um, let me go to Paul Frieda next, who's got something similar. Paul, you want to bring us up to date?
Yeah, real quick, I had a prostatectomy in 2014. I took Lupron for 3 years, and now since 2019, I've been off. I've been in remission. I'm not taking any drugs, and my last blood work like a week ago showed the first time it's above zero point 0.04. Came in at 0.13. So the cancer has returned, and I'm a little scared, but I know there are a lot of drugs that'll put it back in check. But I don't know which drug to take, and I actually saw the the nurse of my oncologist today, and she said she wanted to wait a month and then test again to see if it rises or if it stays stable or what. So so that's probably what we're going to do right now. But any advice I can get, I'd be happy to hear.
This is John again. That's exactly what my team would do in this circumstance. They would
Who, John?
wait. Yeah, this is John. They would wait until it rose to point 0.2, and then since I'm hormone sensitive, they would then go back on hormones. And they also say that they often find that these blips just go away. So that's what they would do. Just what your doc is telling you, or your nurse is telling you to do.
Yeah, and you agree with that?
Who are
Yeah.
you asking?
What?
Who are
If
you asking?
if you're
Well,
asking me, it's
I
yes, I
wanted to
do.
do, I wanted to do immediate, another PSA test to make sure it's not an error, but the nurse said it shouldn't you shouldn't have to worry that much, and to wait a month and then see
Well,
what it does then.
okay. Well, there's another school of thought which we talk about on here quite regularly, and I think we've referenced the paper recently, which is the paper that came out from D'Amico and Peter Carroll, that says that if you're up around 0.14, you've got enough PSA, you've got enough of a level to have a PSMA scan, and that when you wait over 0.2, it can be damaging. Len, you want to talk about that paper? Let me see if I
Uh,
can find it and put it in
yeah,
the
but
chat.
Rick, that pertained only to guys who were post prostatectomy.
Oh, okay,
Yeah,
okay. Not to recurrence.
no. Well, I
Okay,
mean, I guess you could call it recurrence after prostatectomy, but these were guys who didn't have hormone therapy. All they had was surgery, and
okay,
the idea was that if they began treatment, I think it was before PSA got to 0.25, those guys did better than if they waited for intervals after 0.25, like 0.3, 0.35, 0.4, 0.5. Those
okay,
guys didn't do as well.
okay. So that is a distinction
Yep,
from somebody who has been on a holiday and it's starting to come up.
right.
So what would you suggest to Paul Frieda?
Uh, I think the same thing John said. I mean, this is also similar to Tom Jacobson's case, where you can't assume that the lesions that you had years ago are the cause of the rise in PSA. You need to have a scan to see if these are new lesions or just a regrowth of the old lesions. You need to know what to target if you're even thinking about spot radiation. If you're thinking, no, I don't want to do that, maybe I've already had radiation, whatever the case is, then you just I would still get the scan, and then you find out where the lesions are, and you go back on the hormones. That's what I would do.
Mm-hmm. Mm-hmm.
The nurse said she wanted to do a PET scan. Is that different from PSMA?
No, that is PSMA PET scan.
Well,
No.
it may be,
Well,
because
yeah,
there's a
there are a
lot of
couple of PET scans. Yeah,
there's a
but
lot of different
probably,
PET scans. So if she
yeah,
wanted to do a PET scan, you need to find out what type of PET scan, and if it's a PSMA scan, that's what you want.
Well, she talked about an injection.
yeah, they're all injections.
Okay. All right. Yeah.
There's Axumin is a PET scan. PSMA is a PET scan. Um, even
FDG.
the let's see. Well, I don't think they do it anymore, but the old bone scan, the F18 bone scan, that was a PET scan. But I don't think they do that anymore.
Yeah. There's about like 4 or 5 drugs that you can use to arrest the cancer. Which is there one that's the obvious first recommendation?
Well, I think that the first recommendation is to see the extent, because once we know the extent of the cancer, then it points out the drugs. Usually now, when it returns, you'd be looking at least 2 drugs.
Do what?
You'd be looking at least 2 drugs.
At least 2 drugs. Wow. But wouldn't be Lupron?
Yeah, that would probably be one.
That may be one, although we tend to tell people to use Orgovix because you recover quicker, especially if you're older. But there are 2 types of drugs. But this is in a way why I don't want to get into this right now with you, because you're not there yet. We've got to first of all see it. It could be a glitch. So to start, there's lots of options, but getting too far ahead of yourself, and then you may not remember when it comes to the time. So let's first of all find out where you are um, after the next PSA, and then after that, you got to get a PSMA scan, and then after that, there is discussion, like we were just saying. maybe you just try the radiation and see how you do with the spot radiation. Maybe you try the radiation with hormone therapy. There's different alternatives. But as
Okay.
I said to you, your cancer is definitely slow moving because you've been off. Um, you did adjuvant hormone therapy when you had your original radical prostatectomy, and you did radiation back then, and then you've been on no drugs for how many years now? 3,
No, no, almost 5 years, but I
five
never did,
years?
I never did radiation.
Oh, you never did.
Just,
You never.
I had prostatectomy with negative margins.
Well, I think at the time, and I don't want to dig this up, but it's sort of unusual because usually if they give you the ADT, they're going to radiate the pelvic girdle. But I think at the time you weren't comfortable with them doing that, and
Right.
so and so you know, which even more in your case might be that it's localized. So again, having never had radiation, um, and only had hormone therapy, it could well be that what you're looking at is a recurrence in the prostate bed, or if there's even a recurrence, or in close by nodes, and maybe what you got to do now is the adjuvant radiation. But I don't want to. There's no point in getting into the ifs and the ands and the ors until we know what's there, Paul. There's lots
Okay.
of options.
Okay. All right.
And uh, as understandable as it is that you're anxious about this, I would definitely say that it's very, very manageable for somebody like you.
Okay. Well, that's good to hear.
And come to our Men Speaking Freely. I tried to get you in last week. That's what the guys are really good who run that group. Dr. John and Captain Dave. I mean, they're wizards.
No,
Ask
I,
Dr. Jack. We
I
did
had,
ask Dr. Jack. We really helped. We worked on him last. Dr. John worked on Dr. Jack last week. It was a good one.
Sometimes you give me credit that is due to the guys in the group.
Yes, but you guide them. You guide them. Look, I see the guys who were in that group all smiling. I can see it. I see what's going on here. All right. So anything else to put
that's it.
Paul's
Thank you very
mind
much.
at ease before we leave him?
No, thank you very much. I appreciate it.
Okay. Now, let me check. Is there anyone else who's got to cut out early or cut out and maybe come back a little bit later? If so, let me know now. I don't want you dropping out the group if you ask for time and we didn't get to you in time. Okay. Speak or forever hold thy peace. In that case, we are going to talk to Mark Valens.
So I was on a drug holiday for a long time, waiting for the PSA to move, and it finally moved enough. And I got my first PSMA test last week. The bad news is I have a focal lesion in the hip. The good news is I have only one lesion. So I talked to Dr. Borno tomorrow, and I'll see what kind of plan she has. But I'm not quite clear where I go from here. I did send a my chart message to Mac Roach, and he answered so quick. I don't think he looked at the images or anything, but he said irradiate it and then go on ADT. Anyways, that's all I've got now. But any preparation you guys can give me would be helpful.
Well, the first concern I have in your particular case, which I don't think is going to be, tell me again where this spot is that they saw in your hip.
It's at the pubic symphysis, which is where the hips join in the front.
Okay. Well, then maybe it is. But, one of the concerns I have with you is your urinary issues right now.
Yep.
And so we've got to be very respectful of where this radiation is and how close it is to sensitive areas that could cause you problems.
Yep.
How are you doing, by the way? Bring us up to date on those issues, and then we can come back.
It's only gotten worse, and it's on top of the not being able to pee or have to pee every 35 minutes. There's something going on with the rectum or the bowels, so I get big cramps, and that makes it hard to pee. So I'm trying to get in to see a gastro person, and up here in Oregon, it's like, oh, we can get you in 8 weeks. It just they're. Anyways, I'll see if Dr. Borno has any ideas tomorrow. And then I do see Dr. Breyer on Friday, who's a top-notch urologist at
Yes.
UCSF.
Yeah, I was just going to say that to you. I mean, maybe to see Dr. Breyer would be a very good thing. So yeah, because he and of course he works with Dr. Borno, so that's a good thing.
Yep.
But I think the concern would be, and I think Mac's a good person, is you could ask him, how is this going to make sure that whatever Borno and Breyer do, it gets transmitted to Mac, and then check with Mac and ask him, how feasible is it to radiate this spot without aggravating the urinary issues.
Right. Good point.
Anybody else want to add anything or say anything about radiation, getting ready for radiation, spot radiation, etc.? To Mark?
Mark, do they have proton radiation where you're located?
Well, that one of the questions I'll have is, I had my radiation before done at UCSF. If they can do it here in Medford, it'd be a lot more convenient. So I don't know if it's a simple radiation or a complicated one. And
No, my question was proton. Do they have proton where they
I
can
don't even know what they have here. I've only dealt with at UCSF, and I just did whatever Dr. Roach told me to do.
Well, I'm only saying that because of the sensitivity with your urinary tract and bowels, so you can get more of a focal beam that doesn't, affect any other area, and it's only one spot in the pubic symphysis. So it may be useful for you to look into that at UCF, University of California in San Francisco, and see if that's a viable option for you, because that's what I would do if I were in your shoes.
Yeah, they don't have proton beam at UCSF. I think that the likelihood is that they would use SBRT anyway. And although there is now a proton SBRT machine, I don't know I don't know much about how valuable it is, what that means, but there is a proton SBRT machine, and yes, you could discuss that. Don Kramer, you wanted to say something.
I don't think there's ever a time
a bad time to start your Kegel exercises just in case.
Been doing it for a long time.
Got that covered. Good for you, buddy.
Yeah. So, I think the plan of seeing Dr. Borno is great. Seeing Dr. Breyer is great. You got Dr. Roach in your hip pocket to comment on what they say. The likelihood is that they'll be able to zap that particular area. That hopefully will take care of it for a while, but also you're probably going to have to go back on your drugs.
That was my next question, because that's what Dr. Roach said. I had been on Xtandi and Lupron, and you guys are basically recommending either other drugs.
Well, this is from experience here that the combination that seems to be the best right now, if you can get it, is Orgovix and darolutamide, Nubeqa. The Orgovix, because when you come off, your testosterone returns more quickly. Also, the fact that you don't need to take a buffer, because if they're on their game, whoever's prescribing this to you, they should put you on a buffer of bicalutamide before they start you on an agonist LHRH. And if they don't, you need to ask them why. But if they start you on an antagonist like Firmagon or Orgovix, you don't have to worry about that. The pill form, the Orgovix, seems to work well for a lot of the guys here. The side effects aren't greatly different, but the recovery is a lot better. And in terms of the second line anti-androgen, the strength of Nubeqa is that it doesn't cross the brain barrier. So some of the gents feel that they and the studies have shown that the cognitive issues are lesser, and sometimes even the fatigue issues are lesser. And I don't know about, and this is an interesting one, and Dr. John or Dr. Jack, you may have input on this, but I'm wondering whether the mental health issues with depression and anxiety are less with darolutamide.
Makes sense theoretically.
Yeah.
And I can't think of a study though, but I bet I could find one.
I have nothing to compare it with other than my own subjective experience on darolutamide.
Yeah.
And I haven't taken any other drugs to compare it with to know whether or not, it makes a difference. And I haven't had any patients who've been on darolutamide. It's a newer drug, and
Well, I think you're lucky, Jack, in the sense that you never had to go on enzalutamide, or because I think the side effects from that have been noted as being worse. But
yeah,
so the answer to your question, Mark, is yeah, ideally we would like you to we'd like to see you, but it's your choice. This is, we can't recommend, but from the guys in this group, they've done best on Orgovix and darolutamide.
Okay.
Well, I could
I just
add
had
just
one
two.
quick question, Rick. Last time when we talked a couple weeks ago, you
Hold
were a
on,
little
hold on,
early.
hold on your quick question. Go ahead, Dr. John.
Regarding that depression question, I just thought of something. Uh, if depression was a secondary phenomenon to fatigue, then it would happen with all the utamides. And it has been shown that in only a minority of cases is depression secondary to fatigue. So that adds even a little bit more to the idea that theoretically you'd be a little better protected from depression with Darrow.
Okay. Yeah, go ahead, Mark.
Well, you were a little worried about Dr. Borno being so busy with her new project. You're suggesting maybe I'd want to get her to work with somebody, and I don't think I got the name. Somebody at Dana Farber, or was it Aguilar?
Oh, um, it would, if I gave you another name, if she was too busy, it would have been Rahul Agarwal at, who's also at
Yeah.
UCSF.
Okay. Okay. I'll bring that up.
Okay.
Thank you.
But if she'll stick with you and she's available, she's lovely
Yeah.
and smart.
No, I don't think she'll abandon me. She's pretty
Okay.
good.
Okay. Um, all right, we're moving down the list here. Um, Gary Zollner, you had a result from a PSMA scan, I believe.
Yes, thank you, Rick. October 30th, the PSMA PET findings were a zero point 0.9 by 0.9 centimeter PYL avid lymph node, right internal iliac chain with max SUV of 11.8. No other PYL avid. Um, and So I want to thank you and Jim Marshall, Dr. John All at AnCan for helping me sort of focus and bring clarity a few weeks ago. I had I had a subsequent meeting with a GU oncologist who who sort of updated the INOVA radiologist. I have not, they've not made an appointment yet in terms of the radiologist. She shared, my oncologist shared with me that the radiologist's initial answer to her question, to the oncologist's question, is this right internal iliac something that was already radiated during the 40 days of radiation 2016? And the radiologist's answer was, well, yes and no. So, and oncologists did not want to speak or elaborate more for the radiologists, which I respect, I appreciate. And since I haven't had the discussion, in-person discussion with radiologists yet, I don't know what that, obviously I don't know what that means. So I think that's the crux of it. Just real quickly, so the final thing in the report, uh, right? So it's my oncologist said she has a high degree of confidence that it's not just like some kind of benign tissue or something. But while it's very small, it's hot, in her words. And then it said no evidence of metastatic disease to other regional lymph nodes or distant sites. So, I mean, echoing one of our colleagues here of the Reluctant Brotherhood, if I am understanding right, it's one area. I'm glad it's not more than one. So hopefully I'll be hearing from radiologists to set up an appointment within a day or two.
So I'm curious whether that paper the one we were talking about before, whether that made a difference, even though you're not immediately out of surgery, whether that paper made a difference, or what made Dr. Aragon Ching relent on giving you a PSMA scan.
Yeah, great question. Maybe, and your question has led me to wonder, okay, how exactly did I word it to the group several weeks ago? Because it's not that Aragon Ching was not like, she wasn't like in a major way talking against the PSMA. But I think I get the point that since only since July has the PSA gone from undetectable to 0.2 and now currently 0.4. that I think the paper, or no, at her experience, like 38% chance that something will be detected at that level, which means a 60% chance that wouldn't. I did send her the link to the Amico, which of course I'm sure she is already familiar with, and she shared what I'm sure all of you know. But she says, as far as dealing with Medicare, she said you can send them 100 studies, and Medicare is going to do what they're going to do. But I'm grateful that Medicare in fact did approve the PSMA PET scan. That was my first one. So Rick, I'm sorry. I hope I'm answering your question. It's not.
No, it's fine.
Oncologists pretty readily concurred. I just said, I want to do the PSMA, and in fact, I went ahead and made the appointment myself at the nuclear medicine facility, and
Okay.
she was fine with that. But it's a good question. I understand why you asked.
Yeah. So you you are currently back on ADT, correct or
I
not?
am not.
Oh,
No.
you're not. So you're still off of ADT,
Yeah, I'm about
and
30 months into the vacation.
okay. And what is Ching saying about getting you back on ADT now?
Yeah, I mean, she completely understood. She after she explained the conversation with radiologist, um, she said, what are your thoughts, Gary? And I answered her right away because, I was comfortable, and I was accepting that, I don't want to go right back on ADT, especially if I am going to have this um, shorter duration radiation, because I had the 40 days of it in 2016. Then to echo my urologic surgeon, well, how do you know the radiation is working, right? If you're on concurrent ADT, but I know that there's also good reasons to be on ADT. And the last thing I'll mention is just during this 30-month vacation I've been blessed to have been on, oncologist and I had kind of identified a PSA of like 2.0, whether regardless of whether something would show up on a PSMA PET, that I would go back on ADT. Now that in fact something has showed up on PSMA PET, well, I'm not sure that I'm comfortable waiting to a full 2.0. I would certainly any uh, experiences that anyone has to share, I will take that with gratitude. Um, I'm sorry. I hope I answered your question.
Okay. So we have a couple of people with their hands up. I hope it's relating to this. Joel, did you have something regarding this?
Yes, all I wanted to say is, according to Dr. Antonarakis, another GU medical oncologist, he would agree with the PSMA scan in that if you have an SUV 11, that is definitely prostate cancer, he would say. Anything above 10 on the SUV max would be definite prostate cancer. That's it.
Thank you, Joel. Okay, that's good information. My oncologist didn't use those exact words. She said she has a high degree of confidence, but that's helpful. Thanks.
That could be helpful also for Tom Jacobson to bear that in mind. That should be an SUV. What shows up should have an SUV. That's the intensity of the lesion that's showing up of
Sure.
greater than 10. Jim Marshall.
Yes. Gary, how is your testosterone recovery going?
Yeah, Jim, great question. So I think as of 2 weeks ago, it was at 317. Since it became clinically relevant, I suppose, I don't know, maybe 12 months into the 30-month holiday. And since that time, it's fluctuated somewhat generally between 300 and 400. I mean, it took a while to get up to the was it 250? I think is the lower end of the clinically relevant. But the most recent, Jim, it was 317 testosterone.
This is John. I have a question. Maybe Len or Rick can help me. You know, I don't know Gary's uh, risk level, but I'm a little troubled by the statement, how do you know the radiation is working if you're on ADT? Because that statement to me discourages a person from combining ADT with radiation.
Right.
And don't we have a pretty damn good amount of evidence that people go longer before recurrence if they're on ADT after radiation than if it's
Yeah.
radiation alone?
Yeah, but you have to look at the source, and the source was a urologic oncologist. And so, you know, when Gary said that, it flashed lights in my mind. Yeah, that's typical. That's like a typical urologist response. I would question it too. I think it's a good pickup on your part, John. You heard.
Oh, okay. Well, that's a helpful perspective. I will share that um, my 40 days of radiation ended in May of 2016. I had been on concurrent ADT a couple months before the radiation started, during radiation, and I think it seems to me, if memory serves, like certainly 2 to 3 months after radiation ended, I think the dosage of ADT was done. I know that it kind of stays in the system a little bit, maybe another month or
I'm going
two.
to interrupt you, Gary, because it's not right now. It's not sort of pertinent, and I'm concerned about time and moving along.
Sure.
But
If I just one sentence, Rick, to answer the so 1 year later, my PSA started to rise. So that's the only kind of that was a big disappointment. You know, that was 40 days of radiation, and anyway. But I know we got to move on. It's already late here. So thanks for your time and all the
right,
helpful comments.
right. Okay, let's call in the Maui crew. I don't know. Is first we definitely have Peter, and I don't know if Michael Chandler's still with us or if he dropped off, but we at one point had two Mauians here, and we've certainly got one. So go for it, Mr. Kafka, please.
Yeah, I don't know whether I can't remember this being part of a discussion. Uh, anyway, it's kind of new to me. Um, so, just quick background. I was on a drug that none of you were on, Keytruda, and I did it for a year. I've been off of immunotherapy now for 3 months. Um, I've been off of ADT for a year and a half. I've been off of second line um, drugs for at least 13 months. So at this point, I'm not on any cancer treatment for the last 3 months. I was on um, prednisone for 2 months for side effects of my last episode with Keytruda. I was on 10 milligrams for a month. Then we cut it down to 5 for 2 weeks. And then we finished out with 5 every other day for another 2 weeks or so. And as of last week, I went off of prednisone. I did have some withdrawal reaction for sure. Friday, Saturday, last Thursday, whatever. But I'm feeling better now. However, an observational thing is that my testosterone plummeted. And I'm thinking, I talked to Len about this the other day because he hadn't heard about this. I did a little bit of cursory research that my The only thing I've been doing is the prednisone, and it dropped my testosterone by about 60 points. It was never very high with Keytruda. It was only around 190, something like that. Um, but it plummeted down to 36 in my last blood test a week or so ago. First, it went down to 50, then it went down to 36. Um, and has anybody else noticed a correlation between prednisone and testosterone? That's my question, because I certainly notice it. And it's the only thing I can attribute it to.
Anyone?
Well, Peter, did you see the references I sent you?
Yes, I did. And I had already looked at one of them before we
Yeah.
talked. Yeah. Yeah. So
So, I mean, there
think we're
there
onto
is
something there.
literature suggesting that chronic prednisone or glucocorticoid use can result in lower testosterone levels. So that could very well be the reason why your T levels are dropping. The only way to find out is get off the prednisone completely if you think you can, and see what happens.
I'm off of it now. I'm
Oh,
not on
okay.
prednisone anymore. But some of the literature says it could take 4 months to recover. And my testosterone was never very high anyway, because I've been through the mill. But
Yeah.
even 100 would be better.
Yeah.
I'd be able to drive home
Hold
from the
on.
gym at 100.
Hold on. I think we just switched this around somehow. I think what Peter said is when he got off the prednisone, his T dropped.
No, while I
Wasn't
was
it?
on it, it kept dropping.
Oh, while you were on it.
While I was on it and while I was tapering off, it dropped. And now I'm off, and the literature says it could maybe take 4 months or longer to
Well,
recover.
hold on a minute.
I don't know.
Let's just go back. Let's just go back. You've been on the prednisone for how long?
I was on 10 milligrams for a month. I was on 5 milligrams for 2 weeks. Then I was on 5 milligrams every other day for 2 weeks plus a few days, and now I'm off
Okay,
completely.
so this is short-term use of prednisone when you stopped the immunotherapy.
Right, and my testosterone started plummeting.
Okay, so why was the prednisone prescribed in the first place?
Because I was having some pretty heavy duty appetite and intestinal reactions to Keytruda, and my dry mouth was pretty bad. So it was prescribed to counteract some of the Keytruda side effects. And then we cut Keytruda. That was my last. I didn't do Keytruda for the last session.
Okay, David Muslin, you wanted to say something on prednisone.
Yeah, so I've taken a lot of prednisone, Peter. I was taking a high dose of prednisone. I actually started off at 60 milligrams for a very bad hive breakout, and I was on mono darolutamide at the time, and never had that effect of dropping my testosterone like that as quickly as yours.
I've been on 80 milligrams of prednisone once um, for several weeks and didn't do this, but all of a sudden it dropped, and it's the only thing I can attribute it to, unless there's some other mysterious factor. But I don't know. Just it's observational. I asked Antonarakis about it. He did not know. I did it online. I asked my local doc and never got a response. So I'm just curious about it.
The darolutamide by itself is going to enhance the amount of testosterone when you're on prednisone. You're not protected with the darolutamide like David was. And as a result, there's a definite correlation between prednisone and the diminishing of testosterone because it really affects the hypothalamic pituitary axis. So I think, I don't know how long it'll take you to recover, but it's definitely correlated with prednisone. People with rheumatoid arthritis who take prednisone, their testosterone is lowered. Anybody who takes long-term prednisone has an effect on testosterone, women included.
Yeah, I don't think we've talked about this before.
Well, no, we
It kind of
haven't.
threw me for a loop.
Yeah.
Well, I think probably one of the reasons we haven't talked about it is because very often people taking prednisone in this group are also on ADT, so they have no testosterone anyway. So,
Right.
and so, it might not be noted. Dr. Jeff, do you have anything to contribute on this one?
Doctor who?
Jeff.
I'm
So,
not sure he's still
so
here.
yeah, I'm here. The effect of
Oh,
prednisone on the testes, it can cause shrinkage of the testicles and dropping of the testosterone levels. So it's not surprising that being on prednisone will lower your testosterone. However, the amount of testosterone you are on is minimal. 5 and 10 milligrams of testosterone are
Of
not big
prednisone.
doses of, excuse me, of prednisone. They're not big doses.
I
They're
know.
actually pretty small.
I know. That's why it surprised me, but it's the only thing I could figure out. Just, I don't want an answer. I'm just making an observation that from my experience. And when you have low testosterone to begin with, as you all know, when it starts dropping, 70% very quickly, you feel it.
You might want to give
Okay.
yourself the 4 months.
Right.
And what is the plan now for your treatment, Peter?
I'm going to try to go 6 months, and my PSA is climbing a little bit, but it's the last one. It was at 0.73. It'll go up between 1 and 2 within 6 months, and maybe we'll do a scan then, or go back on Keytruda. I don't know. We'll figure it out, but it'll be. I'm trying to get 6 months on a ride for this one. Feels good to be off of treatment.
Well, I hope your testosterone comes back with a vengeance between now and the next meeting next week, okay?
Okay. As I said, it's pretty hard to drive home from the gym after an hour workout with when you
I'm
got
sure. God bless you
testosterone.
for even going. All right, I'm gonna keep moving along, and since Dr. Jeff just had the floor, and he has a question, go ahead, Dr. Jeff.
No, I don't have a question, but I would like to relate two small stories.
Please.
Now, I'm not telling these stories, to display the story, but there's a lesson in each story. And that is a couple of weeks ago, I thought maybe I would try to get some more normalcy in my life, being in the middle of radiation therapy and on Firmagon and abiraterone and prednisone. So I decided to go out to lunch with a couple of friends. I ate a wonderful lunch, and then all of a sudden I started to feel like I was leaving the world. Voices started fading, and I felt pretty crappy. Put my head down on the table. A couple of friends said, "What can we do?" I said, I need to go to the bathroom." So they each took my arm. I walked 4 feet. They tell me, and I collapsed. And they said I had lost consciousness for about 20 or 30 seconds. And I really think what happened was I had the perfect storm, which is I do have radiation colitis, and so I have diarrhea frequently. Um, I'm on a diuretic for hypertension and calcium diminishment in the urine. Uh, and that day, I did forget to take the prednisone. So the first thing I asked for when I recovered was some orange juice, which I drank. And then when I finally got home, I drank some more juice, ate a banana. I didn't go for a potassium level. My point of the story is, though, these electrolytes can drop quickly, diarrhea and a diuretic can really hammer your one's potassium. When my head was down, I will tell you that I checked to see if I was in atrial fibrillation, which I wasn't, or if I was in paroxysmal atrial tachycardia, which I wasn't. Um, but we have to watch potassium levels because dropping them down can do a lot of nasty things. I haven't had a recurrence. I bought myself some new salt and trying to eat foods that are higher in potassium. So that's one warning from recent personal experience. The second thing is,
Hold
and
on before you go. Hold on before you go to the
sure,
second thing. I want to check if anybody else has had any relates to that, has any experience, similar experience, wants to make a comment before we get to the second story.
sure.
Anybody have anything they want to say on that happening to them?
No, but it's
Jeff,
often
is blue
scary.
salt potassium chloride?
Yes.
Thank you. Go ahead,
Tess,
Dave.
It's a scary
so
story,
two,
Jeff.
we got Dr. Jack and we got Captain David. I think let's go to Dr. Jack and comment, and then a comment from David.
I just think it was such a scary story. I'm glad you're okay. You know that it's a very frightening story as you described it. You know, I know the vulnerability of going into atrial fib and how you feel the lights are going out then. And I've had that, but you know, and you checked yourself out and made sure it wasn't that or atrial flutter or anything. But God, conking out in a restaurant like that with dehydration, whatever was going, electrolyte disturbance. It's a good thing to keep in mind. Thanks for sharing. I'm glad you're okay.
Thanks, Jack.
David.
I'm a lifelong colitis survivor, I guess, and I got dehydrated once about 4 years ago, and the same thing happened. I was out for 20 or 30 seconds, came back, and I was just dehydrated. And it happens when you have a lot of diarrhea and you're not paying attention to your electrolytes and the fluid you're taking in. So yeah, I've had the same thing.
Thank you, David. It's always good to hear when somebody else has had a touch of the same thing. You get a little bit of peer support there, Dr. Jeff.
Yeah.
Okay, go on with your second story.
Second thing. So I don't know how many of you guys have had this, but with the radiation therapy, you have to have a full bladder to be given the radiation. If your bladder's not full, they're not going to give you the radiation. They're going to have you drink some more. And what happens on most days is things run a little behind. Guys don't drink enough, or they have to move their bowels because there's too much fecal material. So it slows things up. So when you take the schedule that they give you, when you drink your fluid an hour before, it sometimes stretches into an hour and 15 minutes, an hour and 20 minutes, and holding urine it's a heroic feat to be able to hold your urine, especially on demand, and you can't pee because you want to get on the table. So I had a conversation with the urologist, and I said, you know, it's getting to the point where I'm going to have to start letting urine out before. And so he's giving me a prescription. I'll be starting it tomorrow, a drug called Gemtesa, Vibegron, which is a beta-3 agonist for the bladder. It's given to people with hyperactive bladders, and it kind of allows your bladder to hold more urine before you get that urge to go. And I'm really hoping that this works because this urgency, during the day, there's a toilet to go to, but when you go in for your treatment and you can't go, then I think we need everything we can to be able to get through those 20 minutes.
Yeah, that is not a new problem to us. I think a lot of the guys in this group have been through this, although we've never heard the use of Vibegrant. Anybody want to comment on their strategies for how they manage that? Where's that? Alan Babcock isn't here right now. He's got a few stories on that one. Richard, what do you got to
Yes.
say?
Well, I went through radiation last December and January, and my radiation oncologist told me I had to pee 1 hour before, and then I had to drink a whole bottle of water
Right.
at least 30 minutes beforehand. So when I finally got to the hospital, I had such urges to go. I would go to the bathroom and just pee just a little bit, just to get the urge out of me. And that seemed to work. I still had the full bladder, but just making a couple little tinkles helped the situation. And there was one time I actually peed on the table. It was so bad.
I'm
Yeah,
sure
you're
that
not
wasn't the
alone.
first time they'd seen that.
No.
You are not alone.
Yeah.
Jeff Wood and then Peter Kafka.
Yeah, I had to get the first appointment of the day. I got there at 6:30 when they opened. I'm the first guy in, and then I didn't get backed up by anybody, and that was the only way to manage it.
That's another good strategy, guys. Think about it. You got to get up early, but at least you know when your appointment's going to be. Peter, what do you got to say?
Yeah, I used to have to ride the BART from Walnut Creek into San Francisco, and I knew where the bathroom stop was on the train. But my strategy was I I wouldn't really fill my bladder up until I was called. I kept my bottle and then started drinking fast when I was called in the last 5-10 minutes or so, and it seemed to work out fine. They never bothered scolding me about saying I was too late drinking. I just waited as long as I could and started drinking, and I made it through.
Jimmy.
I tried to time it, and they wanted it real full. And sometimes they made me wait on the table long enough that it got painfully full, and I just couldn't. I didn't want to spend all day there because it would take so long with people who weren't ready and so forth. And I'd be there 2 hours, for a 10-minute job. But a couple of times, I was so full, it was so painful that when they finished, I literally couldn't lift myself off the table. But fortunately, one of the techs was this beautiful woman in her 40s, and she helped me off that table, and she treated me so well, and everything was just fine because of her. That's the only
How,
memory I have.
how did I know that there was going to be a beautiful woman involved in that
You're
story?
lucky, man.
I don't know. Gary Z, go ahead.
Yeah, I'm just echoing. It's been 7 years, but yeah, I was fortunate to get pretty early morning appointments, and I remember it was certainly difficult the first few days, but I just got kind of in a rhythm. But yeah, some days were certainly harder than others, but um, so that's all I wanted to say.
Okay. And then the other strategy is just to have a doc like I did, Mac Roach, who never told me to fill my bladder up. So that was so I never did. It was never an issue. Who knew, right?
So it's a
Okay,
terrible
we're
pun,
going
but I guess it means you were not pissed off then. Okay.
it was not. We're going to keep going here, and we're going to Jeff and then Frank, and then I've still got 2 or 3 other guys, but we're moving along. So let's go to Jeff Marchi first, and then Frank. Go ahead, Jeff.
I was just wondering if one wants to do Provenge, does one need to stop ADT?
No. What gives rise to that question?
I just Hartstart brought up that might be necessary, and I tried to look it up, couldn't find anything in the literature, so I figured I'd ask.
Well, I certainly wouldn't want to go against Dr. Andrea. I have not heard that. I haven't heard it, but maybe she's right. I mean, she knows Larry. Who is it? Who is it in our group that writes to Larry from time to time? Oh, I know. It was Herbie. Herbie used to write to Larry from time to time. We could ask Larry Fong. Anybody, John? Have you ever had any conversations with Larry Fong?
If it's me you're asking, no, I
Yeah,
haven't.
you haven't. Um,
She was
I
involved with the beta testing, I guess, on it, and
Yes, she was. Yes,
is
she
not
was.
real impressed with its abilities to help. But she thought she brought up the
Well,
fact that you might have to stop darolutamide.
oh, she's thinking about the darolutamide. She's not thinking about the LHRH, right?
Well, she didn't mention that, no. And I actually didn't press her really on the subject. I figured I'd ask in here and find out what people thought. But there's no way I can stop those drugs. My PSA pops up immediately if I stop anything. So I can't do it.
Um, she's really pretty knowledgeable because she worked closely with Larry in those years. That's when she was a fellow, and that's when he was doing a lot of the Provenge testing. Anyone, Len, any thoughts on whether you'd have to stop an androgen blocker?
Well, like you, Rick, I have never heard that before.
Yeah.
I kind of doubt that there'd be a problem taking hormonal therapy along with Provenge. Dr. O was just talking about Provenge at the last conference. He didn't mention anything about having to stop um, darolutamide or any other hormonal therapy when you begin Provenge. So I'm very skeptical about that.
Well, thank you. I
I
appreciate
just
it.
looked up drug interactions and I didn't see any.
I think I because I really respect Dr. Hartstock, as you know, and also the fact that she was very much involved working with Dr. Fong together. And I'd just be curious where this comes from. I would be very curious where it comes from, and I made myself a note, and I can drop Larry a line. I kind of passed that Larry connection off to Herb for a couple of years there, but I'm happy to drop him a line and ask him what his opinion is. So I've written it down on a piece of paper, Jerry, and I'll check it out. Joe Commander, did you want to say something on this?
Yeah, I had a question. I thought that Provenge was limited to, what do they call it? Therapy resistant
Yeah,
situations.
castration resistant.
Yeah.
Yes.
So this sounds interesting, actually.
Yes. So the answer is that in order to get Provenge, in theory, you have to have, I think, is three successive increases in your, or two successive or three successive increases in your PSA. But then there's always the question is that whilst you're on ADT or you're not? Because we knew people back in the day who used to stop their ADT so that they could get on get their Provenge, and I'm thinking about Lupron Jim, God rest his soul, Len. And look, I always take with a grain of salt doctors who don't respect Provenge, because in my view, it is a good treatment, but it isn't a treatment that has spectacular results. And we can't really see those results. But there are a lot of people who have taken Provenge and they've been able to do several other treatments along the way. I mean, it's a treatment elongator, is what it is, but we don't see it working. And the reason we don't see it working is because it doesn't actually kill cancer cells. It just encapsulates them and stops them from spreading. That's how it works.
This is John. I'd also like to say to Joe, in case it was implied by his question, that being castrate resistant does not get you out of taking ADT. Even though you're castrate resistant, you still got to keep taking your ADT.
Okay, thank you.
Anything else anybody wants to say on Provenge or Provenge and ADT?
Well, we do know this. The lower your PSA when you begin Provenge, the better response you'll have. And it makes a huge difference.
Huge difference. Yep. Thank you, Len. Yep. Really important. So that is an important factor, Jeff Marchi. Okay, I'm going to keep plugging through. I got an eye on the clock here, and I think I said I was going to Frank Fabish next.
I've been absent for a couple weeks. I had my follow-up call in October with my oncologist concerning my rising PSA and my last CT scan showing the two nodules in my lungs were growing. During the call, my PSA rose again. It's still a small amount from 0.12 to 0.22. And my doc said that because I produce very little PSA, and I've never produced a lot, he said that he really doesn't want to rely on the rising PSA to base my treatment on that. So he said, we're going to rely almost solely on CT scans to monitor my cancer growth. He said that the first thing he was going to do was to schedule an MRI for me to look at the internal organs and the lower abdomen, which I completed last week. And nothing was found in the abdomen or any of the organs. In a week, I'm going to have another CT scan where they're going to focus on the two nodules that were growing, one in my left lung, one in my right lung. He wanted me to remain on abiraterone and prednisone and Orgovyx, and he wanted me on abiraterone. I was on it when I met with him for 6 weeks. He said he wanted me on it a minimum of 12 weeks to evaluate it if it had any impact on the nodules. And so I have on the 21st of this month, I have a follow-up visit, and will have had a blood draw and the MRI and a CT scan in advance of my meeting with my doc. He's considering as possible treatment if he finds that the nodules are continuing to grow. One could be a PARP inhibitor, and he said that he felt that in his estimation that a PARP inhibitor was not a long-term treatment plan. He said it's a short-term treatment plan to bridge to another method of treatment. And he also said, and he wouldn't get into it at that time, he said he has 2 trials that he's going to be conducting that I possibly could qualify for one of the 2. And one of the ones that he said that it was really interesting was one that deals with your immune system attacking the cancer cells. And he just came back from Spain with the test trial that discussed this particular type of treatment. So he said, but that still is based on what they find with the next CT scan and my blood draw coming up in 2 weeks.
So Frank, are you PSMA negative?
He hasn't said that I am, but he said that even when I was diagnosed in 2016, my PSA was only 4.2.
Right. But I'm not asking that. I'm asking why are we not talking about PSMA scans here?
He feels that could be in the future based upon what happens with the CT scan.
No, but why are we even bothering with the CT scans? Why aren't we doing a PSMA scan first? I mean, it
I don't
seems
have
to
an
me,
answer.
well, that's the question to him. I mean, I think most docs today would do a PSMA scan unless you're PSMA negative. Have you ever had a PSMA scan?
No.
I think you
No,
need one.
I had a Oxyman PET scan back
Right,
in
that's
August.
different kettle of fish. I
Mhm.
think if I were you right now, I'd say, Doc, I want a PSMA scan. Now, it's possible, since you don't produce a lot of PSA and you've got these various mutations, you may not make it. Nothing may show. Nothing may show. It may not show because your PSA is too low, but we can see, and we know you have these nodules in your lung, right? They're
Yes,
there still, and they've been tested, and we know that those are prostate cancer, correct?
correct. They've done 2
Right,
biopsies.
right. So it would be very good to do a PSMA scan right now and see if they show up. Doesn't really matter what your PSA level. What did you say it was right now? 0.14?
0.22.
0.22. So, I would definitely give Dr. Mordasabi, drop him a line and say, Doc, I want a PSMA scan. Not can I have one? I want a PSMA scan. If you have a PSMA scan, and if we know you're avid, then it brings Pluvicto into play. Now, is he right about the PARP inhibitors? Some people, Foreman, God rest his soul, got 2 years out of his PARP inhibitor. Professor Bill got a long time. I can't remember how long, but it was certainly more than 8 months. I mean, nothing is permanent, and you have a BRCA2 mutation, which we know. So the PARP is definitely viable, but PARPs are pretty toxic. if it turns out that you're PSMA avid, it's another very large arrow in your quiver, especially since we know you can repeat it.
Mhm.
So I don't understand why Mordasavi isn't. He may just have suspected or assumed you're not PSMA avid, but we don't know. That's my take. Anybody else want to say anything on all of this? No one?
I agree with
Doctor.
you, Rick.
I got worried. I thought everybody had dropped off. I mean, I don't know. What about some of our mods? Like, what about thanks, Len. What about Peter or Dr. John? Or I mean, what would you guys say?
It makes sense to me too, what you said. I have a feeling that the doc was thinking, well, we know for sure what these are. We know that he's got organ metastases. What do we need to, what additional information would a PSMA scan give us that we don't already know? So let's proceed without it. I'm guessing he's thinking something like that.
Mm-hmm.
I don't really know.
But I would respond to that, John,
There could
that
be more metastases, right?
one, there could be more metastases, and two, if we know that Frank's PSMA avid, we've got another treatment option that he isn't even considering right now.
Yeah, Pluvicto, right.
And then the discussion is, well, if you are avid, Frank, then the discussion is, well, when would you want to use Pluvicto, Dr. Modasavi?
So
I will have to bring
another
that up. I will have to bring that up to the team.
another thing that Frank that lit up for me is this new drug that Janssen puts out, which combines niraparib and um, and a PARP inhibitor. Oh no, yeah.
No, Enza or something like that, right?
Huh? No, it has a funny name.
Abiraterone. It combines
Abiraterone, yeah.
Oh, is that
abiraterone.
it? Oh,
Yes, because I made the mistake you just made, John. I thought it was ENS, but it isn't. It's no, I thought it was apalutamide. It's abiraterone and niraparib.
Yeah, they call it Akeega, Akeega. It's one
Yes.
pill.
Yeah.
Yeah, I wonder if they're thinking of that.
Well, are you in that last FMI test that you did? Were you? What was your tumor burden and what was your MSI status, Frank?
I don't know either of those numbers.
Okay. But I think a simpler and a less toxic alternative would be Pluvicto
Mm-hmm.
if you're a candidate.
Mm-hmm.
How does Pluvicto do with BRCA mutations? I don't know anybody with a BRCA mutation who's done Pluvicto. Do we
Don't
know
know.
anybody that's done it?
No, the person to ask that question to, we're delegating it to you, Peter Kafka, is Dr. Antanarakis.
Yeah.
I mean, I think that would be a good person to ask that question, or Dr. Schultz.
Yeah. Yeah, I don't know
But
anybody that's done that.
no. But these are good questions, Frank. But what we're trying to do is develop alternatives for you.
Mm-hmm. Well, first
Frankie,
thing I'll do is talk to the team about why they choose not to do a PSMA and that I want a PSMA, and see what the response will be.
Yeah, tell them you want it because you want to know if you're a candidate for Pluvicto.
Mhm.
All right, we're going to keep going here. We got 3 minutes left. Three gentlemen, a minute each, and the stopwatch is on. No, I'm just kidding. I'll stay as long as it takes. So we've got Jim Barnes, a quick synopsis from Len and Jimmy G. So let's start with Jim Barnes, and then we'll go to Jimmy, and then hear from Len if he can stay up that late. But I know he can. I know Len can stay up late.
yeah, let
So
Jimmy go first before me.
so Jim
Thank you, Rick.
Barnes.
Thank you, Rick. I just completed my Pluvicto treatments on August 14th, and I've had to post Pluvicto scans and what have you. PSA is increasing. My PSA's gone up from basically undetectable up to 17 and a half, and I have disease progression and new lesions and lots of fun stuff. So, but here I am. Think I've expended all the standard of care options. What is a viable next option? And right now I'm talking to my GU oncologist about a clinical trial involving Xofigo and a PARP inhibitor combination, because I'm not, and they're aware that I'm not BRCA positive at all. He said if you were BRCA positive, we would have given you a PARP inhibitor already, kind of answering Peter's comment earlier of why they don't do both. But in this clinical trial, they're doing both the Xofigo and the PARP inhibitor, and because there's a unique interaction between the two that they think has potential to have significant efficacy with the cancer. So that's kind of where I'm at. My other options were chemotherapy, with Jeftana, and or that's kind of all I've gotten, that we've come up with in terms of options. We had talked a little bit about, getting an FDG scan the last time we spoke, and they couldn't make any headway with that. But I guess there's a lot of other things you can do as well in terms of blood tests and blood biomarkers and that sort of thing, sort of like along the lines of a foundation medicine, except they do much more extensive analysis on the RNA side as opposed to just the DNA side, which Foundations does. But I'm just looking for ideas. What's next? What do you do? What do you do when you've gone through all the standard of care options?
When was the last time you did a foundation medicine test?
3 years ago when I was diagnosed.
Okay, you need another one. That's the first step.
Yeah, but would I go with Foundations or would I go with another
It doesn't matter. I mean, you could go with Tempus and to get more RNA, but it doesn't matter. But I the very first step before even talking about trials is let's check and see what sort of mutations you have. That's what Frank Fabish did, and found that he had a BRCA mutation.
Right.
So, I mean, it seems to me that's the.
Is it common for those to change?
I don't want to say it's common, but it's likely.
Okay.
And I go back to Dr. Appelman and say, look, let's see what's going on. I mean, I haven't done one for 3 years. I mean, I think that's the very, very first step.
Yeah, I mean, actually, he's absolutely willing to do that, so I can get that going.
And then once you've done that, Jim, then we can sit down and see what did it say. I mean, what happens if you come back and your MSI high, or you've got a high tumor burden? Then maybe you're a candidate for immunotherapy.
Yeah, I mean, my tumor burden is growing for sure. I
So
started
you
out
know,
with
we
cancer in the
if,
prostate, one spot in the spine, and now I got like 15.
but if you know if your TMB is like well over 4, you could be a candidate, and we've seen Dr. E use that as a reason to give immunotherapy, even when you're not MSI high. Len or anyone else, any other thoughts for Jim Barnes?
That seems like a great idea to me.
Well, that's why they're thinking about giving you the combo drug, probably.
I mean, the main thing is he just wanted. He said, as a sort of buying time measure to use the Zofiga for as many months as I can get out of that. It seems like all these treatments are, let's see how much time we can buy to extend our lives. Which is okay. I'm okay with managing that as long as there's options available.
Well, I think that can somebody respond to Gary Z in the chat window, please? Um, I think that we need more information.
Yeah. His comment regarding getting retested by a Foundations Medicine-like organization was his experience is there's consistently too few actionable items that come back from the test results.
I mean, that makes me angry. That makes me angry. If every medical oncologist said, "What's the point?" then the answer to that is, "Well, what's the point of having precision medicine? Why are we spending all this money? Where's the moonshot going? Is this all a waste of time because there are too few people? What if you're one of the people who does? I mean, it's
I
a
was one of
silly
the, I was one
argument.
of the, I was
That's
one of the
right.
people. My MSI went from stable to high, and that opened the door for me for treatment, and it worked.
I mean, it's a ridiculous thing to say. Oh, well, there aren't enough people. That number can be anywhere from as low as 3%. I've seen it as high as 20% now. It can be 25% for men with recurrent disease have these mutations. Why? Because the disease morphs. And I don't have Frank Fabish's numbers in front of me now, but he came back with 5 mutations last time. And so we got to know that. And the other thing is, and you responded very well to chemotherapy. For me, if I was looking for a holdover, I know you didn't like it, but the Jeff Tanner can be much, much easier. You don't lose your hair. Go on a low-dose Jeff Tanner regime and manage it with a low-dose Jeff Tanner regime for a while and see how you do with that. You might tolerate it well because you did respond well to the treatment, even though it was so hard for you.
My PSA started rising mid-treatment at my sixth session.
Mm-hmm.
So, but if Jeff Tanner showed promise and was less side effects, yeah, I'd give it a shot for sure.
Definitely less side effects. Definitely. I mean, I think only 1 or 2 people that I can remember have found it more toxic than the docetaxel, and most people have found it less toxic. Don Eisner was on before, but he's gone. I think he was on it for ages.
Okay.
And so,
Jim, I just wanted to recommend that Jim talk to his doctor about the Finnish, as in Finland, Finnish protocol, which administers lower dose chemotherapy more frequently. So you can, instead of for instance, for docetaxel, instead of every 3 weeks, 75 milligrams, you give it every 2 weeks for 50, or even every week for 25 at 25 milligrams. And it supposedly it's been shown to be as effective, but less toxic, much more easily tolerated. So talk
Good.
to him about that. If you decide to go the chemo route, talk to him about that.
I heard that a couple times recently, so I'm glad you
Yep.
mentioned it and reinforced what I had heard. So that's something that might be a more viable option. Because I really feel like the Zofiga is kind of reaching back to the bottom of the toolbox and pulling out something that hasn't been around or has been around a long time.
Yeah, well, the theory behind that is that the PARP inhibitors radiosensitize the cancer cells.
Yeah.
Radiosensitized meaning, a radioactive drug like Zofigo will work better. But it's a theory. I'm not sure it's been proven. It's probably early stage clinical trials that they want to put you in. I'd be a little concerned. Maybe you could talk to your doctor about this too. I'd be a little concerned about bone marrow suppression with the combination. You're using 2 agents there that both suppress the bone
Yep.
marrow.
Good point.
Yeah. Well, he did point out how great my blood numbers are, so that's good. So maybe that's less of a concern for him, or maybe makes me more of an ideal candidate. I don't know.
Yeah.
And radium's not obsolete or anything.
Oh no, it's still a viable treatment used in nuclear medicine for sure. It was like I was listening to some Dr. Sartor was interviewed the other week, and he said that Xofigo was developed in an era that before Abi and enzalutamide were around. So he just felt it was kind of dusty, I think. But
Well, Jim, I think the next thing you want to do is definitely to get a sequence. Do you have any lesions that are evident right now?
I mean, I understood every word of your sentence, but I don't understand the question.
Do you have any metastatic lesions that are evident?
I mean, yeah, I have lesions in my spine and in my pelvis, absolutely. All bone lesions, all bone lesions, no
All
soft tissue.
bone lesions. So
Yeah.
if they're all bone lesions, you're probably it's just as well to do a liquid biopsy. If you had some soft tissue lesions, I'd say get a new biopsy. But if you don't have a soft tissue lesion, then probably a liquid biopsy is just as good, because the problem with the bone biopsy is they have to disintegrate the bone, macerate the bone. And
Yeah.
so they lose something in doing that.
How about maybe this is a stupid question. The biopsy that was taken 3 years ago that they
No,
used.
that you absolutely do not want to use.
Okay.
You
Because
you
we're talking
want
about
something.
new mutations, and they wouldn't
That's
be any.
right. You need something very recent.
Thank you.
So I would say that talk to him about a liquid biopsy and let him send it I wouldn't send it to Guardant, but I would send it to Caris. I would send it to FMI. I would send it to Tempus.
How about
Anywhere else.
Boston Gene? Have you ever heard of Boston Gene?
I don't know. I've heard of them, but I don't know enough about what they're doing.
Okay, I had a discussion with them a week or two ago.
Okay.
So they said they provide twice the results that Foundation Medicine does, only because they do all the RNA side of things as well as the DNA side of things.
Well, it's great, but the question is, how actionable is the RNA? That your question to them, it should be, well, how's that going to help me when it comes to treatments? And I don't know, and they don't do a lot of RNA testing. Some of the others do, but I don't know what the RNA gives you right now for prostate cancer.
Okay.
I let Appleman guide you on that.
Okay. Because I was just going to ask for your recommendation, but no, great. That's super helpful.
I like I say, I would use, if it were me, I'd go FMI, Caris, or Tempus. Probably Tempus, from what I hear the guys saying that it's. But then I like FMI. The results have always been good. I know how to read their reports, but I don't think you can go wrong.
Okay. Thank you. That's most helpful.
Okay. We still got Jimmy and Len. Jimmy.
All right, hello.
Hello.
Well, I think I would drop this in case it helps anybody. It's mostly just my little thing, but I did talk to the urologist that your guy referred me to, and he had a very interesting thing to say. For anyone who doesn't know, I had AUS, artificial urinary sphincter surgery, following my other treatments in March of 21 to relieve relentless incontinence. The unit works very well, but about a month after I started getting high fevers, about every 4 to 5 months, 103, 104 fever, lasted for a couple, 3 days. Pretty concerning. Went through a lot of tests, went to an infectious disease specialist, tried a lot of different doctors. Nothing was found. This doctor that was urologist, that was my 6th urologist that I've seen, not for this, but for everything total, that was recommended by Rick's guy. He said that it is possible. He says, since they are trending up, he doesn't know if he would really push for this. But I thought, especially since Rick had been so helpful, that he might be useful to anybody who is ever in the market for one of these artificial urinary sphincters and may be wary. The unit, when it's implanted, is impregnated with something called inhibizone, which is a combination of 2 antibiotics that they don't give by pill. They coat it with the artificial sphincter with it. They also do it for penile implants to prevent infection. However, if you're allergic to these drugs, you might have the kind of reaction that I'm having. You don't really know. Sensitivity or allergy to these. And he said that since he's Indian, he said it's not used in India. They don't like using it because there's its possible toxicity. Although it does supposedly work very well for preventing infection in penile implants, he said that the efficacy of it for the AUS is not so strong. So they don't use it there. They use it here. It was never mentioned to me that there might be any issue with sensitivity. But bottom line is, if I want to go and get tested to see if I have an allergy or sensitivity to either the rifampin or minocycline that they use to create this combination drug inhibizone, then it might give a clue to what's been happening with me. The problem is, if it does turn positive and it's still releasing it into my system, which if I get any more fevers, I will be convinced it still does, but it has been trending in the right direction. If I get more and it's found that I am sensitive to those drugs, they will have to take it out and put another one without them, possibly risking infection. So, as usual, I feel fantastic, and I got problems, but it hasn't bothered me for a while. So I had a fever in September, but I hadn't had one for almost 9 months before that, and the high fevers in succession I've not had since 21 and early 22.
How will they test you for sensitivity, Jimmy?
My primary care can refer me to an allergist who can test for that. I don't know how they do it.
Well, that's very interesting. I mean, this is, you would have thought that the guy that put it in would have raised that, wouldn't you, eh?
That's what I said to Dr. Van Kevison, and he gave me that kind of shrug of the shoulders, which kind of said, well, what can I tell you, pal? He was a really nice guy. And in fact, on his papers that he gave me for the for the wrap up, he said it says right here that I am a very pleasant 67-year-old gentleman.
Well, you know what? We could have told you that without having to pay him the fee. You know.
I like the way also that whenever they have like past drug use, I have to tell them that I was a drug enthusiast in many years past, and when they say past drug use, yes, and then it says denies current drug use. They don't say deny it.
Right.
They don't use them anymore. But
All right,
I don't know.
Jimmy, it's good news because maybe we can get finally to the bottom. Let me ask you, did he say that this is that your reaction is could be an allergic? Is this the sort of allergic reaction it causes?
He didn't seem altogether too sure. In fact, he had an even more remote possibility that he presented that I have a certain form of shingles that may present itself as in this way, even though I do have shingles vaccine. So he's shooting in the dark a little bit, but he admitted that he was. So I don't like taking any time with this. It's just that if anybody ever wants to get the surgery, they need to know there's a couple of things to look out for. I would hasten to add, as always, though, that if you've ever had relentless bad incontinence after prostatectomy, and your sling doesn't work, and your Keels didn't work, and nothing worked, and it's really bad, that is not something you want to live with. Guys are worried about their erectile function all the time, but when we're old, we have sex sometimes. We pee every day, many times a day usually. And if it's not working right down there, you've got a lot of wetness, a lot of stink, a lot of changing pads, a lot of really misery. And that thing works great for me. With all the problems that I've had, I would do it again in a second.
Okay. Well, I hate to say it, but you may have to.
Yeah, well, thanks for saying that. That's what I love about you. Yeah.
No, but Jimmy, if you do have to, it'll solve the problem of your fever, so it'll be good.
If it means it solves if they come back anymore, I'm going to take, I'm going to go straight for this. It has been a bit of an ordeal, but we're all full of ordeals. That's why we're here.
Okay, Peter Kafka, you have your hand up. Is this something new or something old?
I don't have my hand up. I wasn't aware of it. Must have been wandering.
You're on your screen.
All right, I've just taken it off. I've just lowered it for you. Last but not least, Len is going to give us a quick update on. He did not go in person, but he was on top of what happened at the Villages at the weekend. What happened at the Villages?
Well, first let me state that unlike Jimmy's doctor's report, my report described me as a 74-year-old punk with a fade haircut. But
you tell the truth. What do you want?
What can you do? Now, I'll take like less than a minute here. I wanted to say, Rick, I gave the AnCan leaflets to Dave Morse. He said most of them were taken up by the attendees. So
Thank you.
We'll see if anything comes of that.
Okay, don't forget to bill us if you did.
No, it was $13. It's a donation.
Oh, Len, you don't have to do that. Bill us. Anyway, go on. Tell us about the conference.
Well, I just wrote down things that were of interest to me. I'm not sure it'll be of interest to anyone else. I'm not too keen personally for chemo. So he had said that Dr. O, his presentation, only 25% of guys have good results after chemo. Half don't benefit at all. And chemo combos have mostly failed, unlike in other cancers where they're pretty successful. Also, he said to be a candidate for chemo, you should have at least 4 lesions outside of the prostate and pelvic region, or if your PSA is increasing and you are MCRPC. I think that was about it. There are probably a few other things that I can't think of right now, but I'm sure everybody wants to go do whatever it is they do at this hour, so I'll end right there.
Okay.
Thank
Well, thank you, Len. And we didn't have a table this year. We didn't feel it was worthwhile. How many people attended, Len?
Oh, I think it was something like 80 in
Okay.
person, and it turned out it was only about 25 virtual attendees, which is I was doing the Q&A with the virtual, along with Joel Nowak. Oh yeah, just really quickly, I had a radiation oncologist consult whether or not my spot should be radiated. It's too bad Jack is no longer on the call because I was going to give him a shout out for he had recommended Alan Pollock in Miami, and this radiation oncologist in Sarasota studied under Pollock, and he said, "I'd like to make a referral for you to Dr. Pollock in Miami. I'd love to hear what he thinks because the guy I spoke to said, I'm really not sure if radiation would benefit you or not." So I like this guy for that reason. Like how many docs would say, well, I'm not sure. I'd like you to get a second opinion to mine. So anyway, if you happen to be in the Sarasota, Florida area, his name is Dr. Kunal Sagel. And you probably won't remember that, but you can always ask me later. And that's it.
Okay. And when are you going to Miami?
It's going to be a video visit, and it's scheduled for November 16th.
Oh wow! Excellent. That's that you can do it video. Fantastic.
Yeah.
Okay. All right. Well, bring it up again and tell Dr. Jack he'll be delighted to hear that. All right, guys. Thank you for hanging in there.
Thanks, Rick.
My pleasure. Good night, everybody.
Good night. Thank you.
Good night.